Hello and welcome to the topic Eczema in the Dermatology module. By the end of this topic, you should be able to define eczema, explain the pathophysiology of eczema, outline the causes and classification, describe the clinical manifestations of eczema, outline the investigations, discuss the principles of management, and discuss the complications and prognosis of eczema. Let's get started. Eczema is a group of medical conditions in which the skin becomes inflamed, forms blisters, and becomes crusty, thick and scaly. The word eczema originates from Greek eczema, which means something thrown out by heat. Atopic dermatitis is the most common type of eczema. It is a chronic, pruritic, inflammatory skin condition. In Greek terms, atopic means something unusual and being out of the way, while derma refers to the skin or leather and itis stands for inflammation. So let's look at the physiology. There is a balance between subsets of important T cells such as Th1, Th2, Th17 and Th22. In addition, our epithelial forms a barrier to protect itself from external environmental insults and allergens. It also provides tissue interface to balance the communication between the internal and the external environments. So there are two main hypotheses to the pathology of atopic dermatitis. The first hypothesis is regarding primary immune dysfunction, where there is imbalance in the T cell subsets in which the T helper 2 cells predominating the system. This results in the production of type 2 cytokines such as interleukin 4, interleukin 5, and interleukin 13. As a result, there is increase in IgE released from the plasma cells. T helper 2 cells are known to be significant sources of the itch-inducing cytokine and production of pruritogen interleukin 31. The second hypothesis is the presence of primary defect in the epithelial barrier of susceptible individuals. This allows entry of antigens and resulting in the production of inflammatory cytokines. Individuals with mutations in the gene encoding filaggrin are at higher risk of developing atopic dermatitis. Filaggrin is a key epidermal barrier protein. Its defects will cause release of epithelial cell-derived cytokines such as TSLP, interleukin 25, and interleukin 33, resulting in inflammation, eventually resulting in increased transepidermal water loss causing xerosis. In addition, impaired epidermal barrier will lead to pruritus, excoriation, and increased risk of skin infections. Acute immune dysregulation due to underlying inflammation will cause formation of vesicles and papules. If vesicles and papules were disrupted due to scratching, it will ooze, form crust, and causing dry scale of the skin. With chronic immune dysregulation, the skin will be hyperkeratotic and scaly. Atopic dermatitis is multifactorial. For genetic causes, individuals with loss of function mutation in filaggrin are at the highest risk of developing atopic dermatitis. Other gene mutations include genes that encode proteins involved in epidermal proliferation and differentiation of inflammatory cytokines. Individuals with skin infections such as Staphylococcus aureus and herpes simplex virus are more prone to develop atopic dermatitis. Reduced exposure to various childhood infections and bacterial endotoxins has found to be a risk factor for atopic dermatitis. Extreme of climates such as extreme heat, cold and dry atmosphere can exacerbate and trigger the symptoms of atopic dermatitis. Acute food reactions such as urticaria and anaphylaxis are commonly encountered in children with atopic dermatitis. So atopic dermatitis can be classified by its phenotype. In individuals with pure atopic dermatitis, there will be no associated respiratory symptoms. Pure atopic dermatitis can be further classified into intrinsic and extrinsic types. For intrinsic types, there is no specific IgE sensitization detectable and total serum IgE is not elevated. While for extrinsic type, IgE sensitization against inhalant and or food allergens are demonstrated in skin test or serum. Another phenotype is mixed atopic dermatitis, in which there is concomitant respiratory allergies such as asthma or rhinitis, and it is mandatory to prove presence of polyvalent IgE sensitization against inhalant and foodstuff. Atopic dermatitis can also be classified based on its onset. For acute atopic dermatitis, it is new onset with less than 72 hours and causing flare-up of symptoms. While in chronic atopic dermatitis, there are signs of chronic inflammation such as lichenification of the skin. Patients with atopic dermatitis will complain of skin changes such as itchiness and dry scaly skin. Physical exam reveals dry scaly skin lesions with lichenification. The eczematous lesions are commonly found in facial, neck, extensor surface in children, and for other age group, flexural surfaces are more commonly involved. Groin and axillary regions are spared in atopic dermatitis. With scratching, there will be excoriations of the skin, oozing from the vesicles and crusting. There might be atypical vascular responses such as facial pallor and delayed blanch response. Other skin manifestations include keratosis pilaris, pityriasis alba, hyperlinear pumps, and ichthyosis. The ocular, oral, and auricular regions might be involved as well. Atopic dermatitis should be suspected if patient presents with eczematous lesions at the facial, neck, extensor surface in children, but flexural involvement in other age group which spares the groin and axilla. However, supportive lab investigations can be done to rule out differential diagnosis. IgE levels can be done to support the diagnosis. Its level might be high or normal depending on its phenotype. Skin prick tests and patch tests are done to identify triggers and hence is a part of management as well. Skin biopsy can be done if diagnosis is uncertain. Histology report will show acute, subacute, or chronic spongiotic dermatitis. Spongiotic dermatitis is represented by massive intercellular edema of the epidermis with widening of the intercellular spaces between keratinocytes and elongation of intercellular bridges. Skin swabs for organisms if there is suspected skin infections, staphylococcus or streptococcus might be isolated, and antibiotic sensitivity can be done. PCR test is done for herpes simplex virus to diagnose eczema herpeticum. A full blood count is done to look for thrombocytopenia, which helps to exclude Wiskott-Aldrich syndrome. This is a X-linked disorder which is characterized by the clinical triad of microthrombocytopenia, eczema, and recurrent infections. The mainstay of treatment is moisturization and use of steroids to control inflammation. Moisturizers such as white petroleum or Aquaphor can be applied all over the body after shower while the skin is still wet. This is done to seal in moisture and to allow water to be absorbed through the stratum corneum. Patients are encouraged to take frequent baths with addition of emulsifying oils for 5 to 10 minutes to hydrate the skin. Topical steroid is the mainstay of medical treatment. Initial therapy consists of hydrocortisone 1% powder in an ointment base to be applied 2 times daily to lesions on the face and in the folds. For lesions on the trunk, a mid-strength steroid ointment such as triamcinolone or betamethasone valerate is applied 2 times daily until the eczematous lesions clear up. For steroid-free management, immunomodulators can be started. Tacrolimus 0.1% for adults and 0.03% for children. Tacrolimus can cause stinging sensation following application, but this can be minimized by applying the medication only when the skin is dry. Biologic therapy such as anti-interleukin 4RA therapy, which is dupilumab, Janus kinase inhibitors, topical phosphodiesterase 4 inhibitors are useful for atopic dermatitis lesions. Probiotics has found to be effective as bacterial products may induce an immune response of the Th1 series instead of Th2 and could therefore inhibit the development of allergic IgE antibody production. Individuals with atopic dermatitis are encouraged to wear soft clothing such as cotton to avoid exacerbating the symptoms. Staying in cool temperature are helpful and usage of humidifier helps to prevent excess drying of the skin. In addition, their clothes should be washed in mild detergent with no bleach or fabric softener. If trigger food has been identified, patients should avoid it diligently. Atopic dermatitis can result in a variety of complications. In short term, it can cause skin infection. For bacteria group, common organisms found are Staphylococcus aureus and Streptococcus pyogenes. Co-infection of virus in individuals with atopic dermatitis will lead to molluscum contagiosum, eczema herpeticum, eczema coxsacchium, eczema vaccinated. Fungus such as Trichophyton rubric, Epidermophyton, and Malassezia furfur can also result in opportunistic infections. When the skin is infected, it might result in septicemia, osteomyelitis, septic arthritis or bursitis, bacterial endocarditis, or herpes virus encephalitis. Erythroderma is another acute life-threatening complication of atopic dermatitis. Now, chronically, there will be post-inflammatory hyper or hyperpigmentation. Chronically, there would be post-inflammatory hyper or hypopigmentation. With excessive and long-term skin lesions, it can cause vitamin D deficiency. Not to forget the psychological burden in patients with chronic diseases. They are also at risk of loss of school days, sleep disturbance due to pruritus, and poor quality of life. The prognosis of atopic dermatitis varies according to individuals. 1/3 of the patients will later go on and develop allergic rhinitis, while 1/3 of them will develop asthma. Symptoms of mild to moderate atopic dermatitis are likely to persist into teenage years or beyond. Patients with family history of atopic illness have poorer prognosis. Same goes to those living in the southern states due to environmental factors. Individuals who continues to be exposed to pollen, wool, pets, cigarettes, fumes, trigger food or drinks, and strong soaps and detergents have poorer outcomes too. Atopic dermatitis is the most common type of eczema, and it is a chronic pruritic inflammatory skin condition. It is thought to be caused by primary immune dysfunction with imbalance in the T cell subsets and primary defects in the epithelial barrier, which allows entry of antigens. It is multifactorial. Causes include genetic factors, infections, hygiene during childhood, extreme of climates, and food antigens. Suspicion of atopic dermatitis should arise if patients present with eczematous lesion in the facial, neck, extensor surface in children, and flexural involvement in other age group with groin and axillary regions spared. Clinical diagnosis of atopic dermatitis is sufficient. Lab tests are done to support the diagnosis or identify triggers. Atopic dermatitis symptoms can be controlled by adequate moisturization, use of steroids, immunomodulators, and biological therapies. Non-medical efforts are equally important. Non-medical efforts are equally important in prevention and control of flare-ups of atopic dermatitis. So we have come to the end of this topic. Thank you.